Doctors. So today we're going to talk a bit about Mrcp PACE's cardiology station, and I'm going to talk about the ventricular septal defect. And this is a very common cardiology station case, and it has appeared in the recent exams as well. So I thought it is worthwhile to make a short video about this cardiology station. Let's move on. Normally, you have a case scenario in the short stations as well, but the scenario is very small, just maybe one or two lines, and just to give you some idea about the case. Well, in comparison to this, the consultation station, they have a bit longer scenarios because the station is 20 minutes. So in this let's move on to the case scenario. Mr. Patel is a 25-year-old male, and he presenting to the cardiologist clinic, and he reports symptoms of exertional dyspnea, fatigue, and occasional palpitations. So as this is a cardiology station, so we're not going to take any history from the patient. We will proceed with the examination. So after taking the consent and introducing yourself, you start your cardiovascular examination. So we're going to start by the inspection, and we would like to observe for any signs of cyanosis, any clubbing or digital hypertrophy, which actually indicates a long-standing cyanotic heart disease. And in addition to this inspection, look for any signs of heart failure, and look for the JVP, any hepatomegaly or peripheral edema. Moving on to our examination, then you're going to start with the palpation. So on palpation, palpate for the point of maximal impulse to assess for displacement, which is obviously indicative of cardiac enlargement, and check for any palpable thrill over the precardium, particularly in the left lower sternal border, which is suggestive of a VST. Now remember, this thrill is quite specific, so must look for this palpable thrill. Then you will going to move on to the auscultation. So in auscultation, we're going to listen for the heart sounds, noting any loud, harsh systolic murmur with a palpable thrill over the left sternal border. So it is a loud, harsh systolic murmur, and it is on the lower left sternal border. And also assess for any signs of pulmonary hypertension, and that is loud P2 component of the second heart sound and a systolic ejection click. Briefly, this systolic murmur, it can be present in the other cardiac conditions as well, like it can be present in the mitral regurgitation as well. But mitral regurgitation, remember that the murmur radiates to the axilla and is usually heard at the loudest at the mitral area. So in comparison to this, in the VSD, normally we'll have harsh systolic murmur, which is at the lower left sternal border, and this is quite characteristic of VSD. So what about the differential diagnosis? Well, VSD, we're going to put this is the most likely diagnosis given the clinical presentation and positive examination findings. Other differential diagnosis to consider is atrial septal defect. We consider this if murmur is located in the upper left sternal border and there are signs of right heart enlargement. So remember this DD, that murmur is usually located in the upper left sternal border. What about the other differential diagnosis? We'll also put patent ductus arteriosus here, but is in this the murmur is continuous and is loudest at the left infraclavicular area. So these are the three differential diagnoses which we're going to discuss in the differential diagnosis. Briefly about the investigations and management. We like to do the echocardiography because we want to confirm conformity. It is a conformity imaging to assess the size and location and hemodynamic significance of VSD. ECG is important because it gives us some idea about the chamber enlargement, conduction abnormalities or arrhythmias which are associated with VSD. We like to do the chest X-ray, which mainly to assess for any signs of cardiomegaly or pulmonary congestion, or pulmonary vascular marking, which are suggestive of increased blood flow, and finally cardiac catheterization, which is reserved for cases requiring hemodynamic assessment or preoperative evaluation for surgical repair. Um, I have put these investigations and management approach and differential diagnosis because normally these are the questions which usually asked in the examiner. So once you are doing the examination and your clinical findings are consistent with the ventricular septal defect, so you should start rehearsing the information and so how you will reply to the potential questions from the examiner. Once you have finished your examination, then you're going to proceed with the presentation. So here's a brief presentation. Good morning, my name is this. Today I'll be presenting a case of 25-year-old male, Mr. Patel, with a known history of a ventricular septal defect. Now here you can put, if whatever information is written outside, you can just mention here also in your presentation. Mr. Patel presents with symptoms of exertional dyspnea, fatigue, and occasional palpitations. And then you're going to talk a bit about your examination findings. So on examination and observe, we start with the periphery, where there is some cyanosis and digital hypertrophy. And palpation reveals a palpable thrill over the precordium, particularly in the left lower sternal border. And auscultation reveals a harsh systolic murmur with a palpable thrill over the lower left sternal border. And these clinical findings are consistent with the ventricular septal defect. So given the clinical presentation and examination findings, the likely diagnosis is VSD, and investigations planned include echocardiography to confirm the diagnosis and assess the size and hemodynamic significance of the defect. So this should be your brief presentation about the case of VSD. I put some questions which are usually asked by the examiner if your case is VSD. Some of the common questions are, what are the clinical manifestations of VSD? So clinical manifestations actually include the symptoms of heart failure. So like we know what are the symptoms of heart failure, like exertional dyspnea, fatigue, or poor feeding and influence if it is a small and frequent respiratory infection. So on examination, there may be other signs, clinical manifestation, which includes cyanosis and digital clubbing and a harsh systolic murmur with a palpable thrill over the left sternal border. So almost a repetition of what we have talked before. How does echocardiography help in diagnosis and management of VSD? Where echocardiography is visualize the VSD and assessing it is helpful in assessing its size and its location and hemodynamic significance, and also helps in determining the presence of associated abnormalities, and it also guides the management decisions and monitoring the disease progression. Indications for surgical repair of a VSD. This is a very common question which is asked by the examination, so you must be prepared for it. Indications for surgical repair include large VSDs causing significant hemodynamic disturbances, if there is a failure of conservative management and development of complications like pulmonary hypertension or heart failure or infective endocarditis. Early repair is often recommended and to prevent these long-term complications. So what are the different types of VSD and how they differ in terms of clinical presentation? So normally the VSD, it can be classified anatomically as perimembranous, muscular inlet or outlet. Perimembranous VSDs, these are the most common, and these are often associated with aortic valve prolapse or regurgitation. Muscular VSDs occur within the muscular septum and they usually close spontaneously over time. And inlet and outlet VSDs, these are less common and they may require surgical repair due to their location near the atrioventricular or semiliminal walls respectively. So remember these different types of the VSD. What are the potential complications associated with untreated VSD? So it can lead to complications like pulmonary hypertension, pulmonary vascular disease, and congestive heart failure, and other complications include infective endocarditis, and there is also a risk of a paradoxical embolism or Eisenmenger syndrome. Eisenmenger syndrome, normally it is quite rare actually. Early surgical intervention is often recommended to prevent these complications. How do you differentiate between innocent murmurs and pathological murmurs in patients with VSD? So you remember these innocent murmurs, these are typically soft, short and systolic, and they hurt best at the left sternal border, and they do not have do not have any associated symptoms or signs of heart failure. Okay, while the pathological murmurs which are associated with VSD, these are louder, these are harsher, and they may have a palpable thrill. So they are typically accompanied by symptoms of heart failure. Patient may have a dyspnea, fatigue, and obviously poor feeding in infants. What pre-op assessments are necessary before surgical repair of a VSD? So pre-op assessment, we want to do the echocardiography because we want to evaluate the size, location, and hemodynamic significance of the VSD, as well as access for associated abnormalities. So additionally, tests may include, we want to do the cardiac catheterization for hemodynamic evaluation, and ECG to assess for conduction abnormalities, and a chest X-ray to evaluate the cardiac size and pulmonary vasculature. Finally, what are the long-term outcomes for patients undergoing surgical repair of VSD? So, surgical repair of VSD, generally it has a favorable long-term outcome with significant improvement in symptoms, and it is helpful in reducing the risk of complications like heart failure, infective endocarditis, and normalization of cardiac function. But patient obviously requires long-term follow-up for potential residual valve defects, valve dysfunctions, or arrhythmias. Okay, so this is a very brief discussion about the VSD, but I have tried to cover all the relevant points which can come in the cardiology station regarding this case. Hopefully, my presentation will help you in preparing for your MRCP PACEs, and I'll see you in my next presentation. Thanks a lot.